let's try and pop that through there, hopefully. Can you hear me now? Hopefully you can. Please let me know, and thank you very much to Mania to give me the heads up in the chat. Glad to hear that that is doing a little bit better. There we go. So as I was trying to say, I'm having all kinds of IT issues tonight, but we are finally getting there and getting ready to go live. So tonight we are here to practice for the 2023.2 RACGP CCE exam, and to get our careers in the best possible way moving forward and moving ahead with our lives, because I don't know about you guys, but these exams hang over your heads for the longest time and it feels like they are never over. Rest assured, there is a light at the end of the tunnel and it is not a train hurtling towards you. For those who haven't had much chance to actually practice yet, I want to let you know that we still have plenty of time. We still have 80 days before the exam, which means even if this is the first time you're even picking up a book and starting to think about it, you still have lots of time to actually get in there and succeed. Probably one of the most important things to do is to actually see patients. This is one of those things where the AKT and KFP exams can be learned through books. Really, the CCE exam reflects your communication skills. So one of the best ways to prepare is to actually do your normal day-to-day job, get paid for it, which is always fantastic, and to apply all the things that you are learning to your patients, and to spend a bit of time as well at the end of the day or once a week, or set aside some time, calendar block some time to actually go through those cases and think, if this was a CCE question, how would I be responding to it? What would I be doing differently? Would I be doing anything differently? Now, tonight I was hoping to actually get through a couple of cases, so glad to see we've got some people in the chat here. And I thought I would, first of all, spend a bit of time discussing how we actually intend to do that, and that is through something called Video Ninja. So it is a similar to Zoom. I think we've all gone through the pandemic by now and know how to use these kinds of softwares. This is a web-based software for streaming webcams and being able to have live, very low latency interactions. So for those who are actually interested in participating, I will actually pop up onto the screen here a QR code. Now you can actually scan this with your phone, or if you want to jump in and participate online, there is another link I can actually throw to you, which I'll pop that into the chat now, which will give you the chance to participate live into the stream. So it should be in the chat there now. I'll pop it up onto the screen here as well. And of course, this is a rather long link. And so for those that do want to join after the fact, I'm sorry, it's live, you won't be able to. But for future, click the link into the chat and you should be able to jump in and join us. Now, this basically pops you into a queue where we can have multiple people all trying to jump in to participate. It will log you in as a guest. You can pop your details, your name in if you're happy to do that, and we can bring you up onto the screen for everyone to see. Now, the one trick I have found through testing this out is that if you are using it on your phone, for example, or computer, you are best to mute YouTube while you're doing it. Otherwise, you'll end up hearing the echo of yourself back. And getting some feedback, because there is a bit of difference in the latency, the delay between speaking between YouTube and Video Ninja. YouTube has a couple of seconds delay. Video Ninja is pretty much instantaneous. So to avoid that little feedback loop, I would strongly encourage you to mute YouTube while you're participating in Video Ninja. Now, of course, not everyone's going to want to be participating on live chat, which is more than fair enough. And so if we don't have any live participants today, then I will look at actually discussing through a case and getting some participation from the chat about what potential answers could be. Of course, without further ado then, how about we bring up our presentation. Now again, the CCE exam is 20-minute stations. You get 5 minutes of reading time and preparation time. You are allowed to make notes on paper in that time. And from that moment, you are then able to plan out your attack for the 15 minutes, which is allocated to the case. You can have clinical discussions or, case discussions or clinical scenarios, and the way that will work will be slightly different. So if you can see in the STEM that you're asked to be taking a history or getting details from the patient, then you should be managing your own time and not waiting for any prompts from the examiner. If you see a wall of text, you should be essentially having a pretty one-to-one conversation with the examiner and answering questions from there. Now, I've chosen to make this a bit interactive tonight, so if this is something you're happy to try and practice, then I will encourage you to throw some answers into the chat. We'll see how far we go. Now, we'll pop 5 minutes onto the clock right now for some reading time. And of course, if you want to participate, feel free to pop some answers into the chat. Otherwise, you can always jump into video.ninja and we will have a look at how things look from there. So, without further ado, 5 minutes on the clock for reading time and preparation. Your time starts. And now. All right, now I had to set this up in case there was someone that was going to be participating with us tonight. That's all right. What we'll do instead is move it through and we'll pretend we've got those 15 minutes on the clock to talk through the things that we would be saying to actually answer this question. So this is essentially a combination of our preconception counselling consultation combined together with our first presentation in pregnancy. Now, step one, of course, is we want to confirm the pregnancy, so we'd be repeating the urine beta-HCG test, which would be positive in this circumstance, and you would have that fed back to you as well. So we'll be organising our first trimester bloods, and for this as well, we have something prepared which you can use to give you a bit of a template. Let me just bring this up on the screen. If I pop that into there and bring here, it's almost as if we had this prepared earlier. So on the Generally Practicing website, we do have a summary for preconception counselling, which a lot of this does overlap through with our first trimester bloods and screening. Now, of course, we are confirming pregnancy. If not yet pregnant, we'd be talking about breast examination, cervical screening. Given this is her first pregnancy, we don't have to worry about previous pregnancies' intervals. Pardon me. But I would still be confirming with the patient just to confirm this is definitely your first pregnancy. You've never been pregnant before. Really, really important, particularly on that first presentation, is to record their BMI. So you're needing an accurate measurement of height and weight, and you'd be requesting for these recordings. And you would be given that to give an indication of BMI, which in this circumstance would be normal, under 27. We would recommend against being overweight or underweight, both of which have risk to infants, fetuses, and we would encourage them to remain active and healthy and maintain that moderate intensity exercise, again going back to that 5 days a week, 30 minutes per day. Now, consider nutrient deficiency. This is where screening for what kind of diet they're currently eating would come into play. Again, in this circumstance, the diet would be fairly stock standard Western Australian diet. And comorbidities, again, we don't have to worry about because, thankfully, there are none. Now, in pregnancy, we do recommend complete cessation of alcohol, which she does consume. So we'd be reinforcing the fact that there is no safe level of alcohol to consume in pregnancy. Tobacco isn't an issue in this case, but again, we would be exploring this. And in this case in particular, if I bring this back over to this case here, we have got in here the occupation is a factory hand for a large online retailer. Of course, we can't say which retailer that would be. Now, there is something noteworthy in this, in that factory hands and factory locations are incredibly terrible for secondhand smoke inhalation. And if that was touched upon, that would be something that would be volunteered. And so, again, would be a discussion to be had about making sure she minimises any contact with secondhand smoke, and that may necessitate modification to her duties in the workplace as well. We'll bring up the other screen again. Now, immunisations, again, we were actually covered for immunisations. Those were given, so we don't have to worry about those. Supplementation's incredibly important. This would be folic acid. In her case, she would be in the 0.4 to 0.5 milligrams per day for 1 month. Well, she is pregnant, so we'd be ensuring that for the first trimester she is taking it. She isn't taking it at the moment, but you would strongly recommend her to encourage it as quick as possible, and you would be asked about, well, what is the reason for that, and you would be talking about the spinal cord development and its important role in making sure that we have a good chance of that developing as normally as possible. You would also ask about history of spinal cord issues in the family, of which there would be none, and iodine supplements of 150 micrograms per day for all pregnancies. Reinforcing our torch infections, so toxo, syphilis, varicella, mumps, parvovirus, HIV, listeriosis, rubella, cytomegalovirus, and herpes simplex. And really, this is don't eat all the good things. Anyone who has been pregnant, any partner who has gone along with their That would be a faux pas. Go along with their partner in terms of abstaining from these kinds of foods or environments during pregnancy knows this can be really difficult. And I will say, after the birth of our children, the first thing I had to go out and do was get my wife a sundae from McDonald's, because it was one of the few things she'd really craved through her pregnancy. There you go. So it is checking for those risk factors there. For toxoplasmosis, it's primarily going to be garden or cat litter, any undercooked meat or unpasteurised milk products, making sure you're washing all your fruit and veggies really carefully. Cytomegalovirus, it's really, again, good hand hygiene. If they're working with children or healthcare workers, then they should be wearing gloves, particularly around things like nappies. And listeriosis is delicious, delicious soft cheeses. Again, anyone who has been pregnant or has had a partner who was pregnant knows this is a often much harder thing than it should be. Pardon me. All right. Now, of course, we also have to talk about pathology. So we'd be setting off screening for each of these things and, again, confirming our immunisations, confirming our serum beta-HCG level. Now, expanding that into STD screening, you would actually modify your STD screen according to what's prevalent in your area. And so, for example, where I'm working at the moment, we unfortunately have high prevalence, or prevalence rather, of syphilis and chlamydia. So we'd be definitely screening for both of those things. But again, that would depend on outbreaks and particulars of your setting. And if ever in doubt, I would encourage you to actually contact the obstetricians or obstetric unit in your area to get guidance there. And don't forget, of course, we've also got the health pathways, which are incredibly invaluable for giving you region-specific information. Now, also a good opportunity to start talking about what are the things we actually need to do during early pregnancy, potentially a little bit early for the first consultation, but I tend to actually flag these in that consultation to make sure that they actually know kind of what are the things going to be coming up as well. So again, thankfully, it's almost like we knew about this. We do have a little bit of a cheat sheet prepared here up on generally practicing. I will bring this one up here. Up to here. Now, we've gone through our preconception counselling. We've been ensuring the cervical screening's up to date, as we've already said, and it is in this setting. We'd be organising our serology, assessing for proteinuria, and the rest of the bloods, including talking about our first trimester screening as well. Now, these days it is a little bit more complicated in that we do have two options available. One would be the non-invasive prenatal testing, which is actually looking at chromosomal abnormalities and being able to run specific gene sequences to check for more common abnormalities. Now, the benefits to this is that it can be done just through a simple blood test. It does have an out-of-pocket cost associated with it, but is incredibly sensitive for a lot of these conditions, bearing in mind being gene markers. Just because gene markers can return positive does not necessarily mean that the child will present with the phenotype of whatever condition. You're also more likely to pick up on conditions that may not necessarily have clinical significance, and things here would be things like XXY. Sometimes there can be rather profound phenotype changes, sometimes they can be very minimal, and that can cause potentially undue distress in the parents, where often will be the case the person that has that may never actually know that they have any abnormality at all, or unusual chromosomal count. Now, the other benefit to the non-invasive prenatal testing is that it can be done earlier. So you get it done at 10 weeks or from 10 weeks, and you can find out the gender from that time point as well. I always like to check with the parents if that's something they do want to know or not. You don't have to get the gender revealed there. And what I have done, not infrequently, is to actually have it down on the test results. And if the parents aren't wanting to know, then I cut that information out from the results I give to them, in case they do change their mind later on. I have had a few that have changed their mind, knowing that, and this is with their consent, of course, that information is there should they want to know. Often the cat's out of the bag once they get a bit further along, and you can start to see genitalia more obviously on ultrasounds. Coming into that as well, you'd be warning them that at around the 6 to 8, ideally 7 week mark, they would be getting their dating scan to actually see whereabouts they are to allow for better timing. And that's where I generally would... we haven't actually talked about the more standard first trimester screenings. That's using our beta-HCG and PAP-A serology, combined with the fetal morphology scan or ultrasound scan to assess for nucleolucency. And really we're talking about screening for things like trisomy 21 or gross developmental abnormalities. Now, the things I would counsel them about this test is that while it is a fantastic test, it is slightly less sensitive and specific in terms of these abnormalities than necessarily gene assays would be or chromosomal assays would be. But is certainly cheaper, is still recommended as part of routine antenatal care, and could be done as an alternative to the non-invasive prenatal testing. All right. Now, you can see here we've covered a lot of information, and so you would also be mentioning things like, I would make sure that this is all provided in written material for her to take down. You would give her the opportunity to ask questions as well. And from all the things we've spoken about there, that would cover pretty much everything that there would be to talk about for that case. So, what do we do for the rest of the time? We twiddle our thumbs, we make small talk, and we wonder what the next case could be. For the purpose of today, though, I'm going to cancel that one out, and we'll start looking at what the next case could be. So, we will bring up our screen once again. We will put 5 minutes on the clock. If we can bring that up, there we go, and our time starts now. All right, so what we'll do here is, in fact, go back to this screen here. We've got 15 minutes on the clock. And so in this case, we're just going to talk through what the relevant findings would be. So taking a history from this patient, you would discover it is a 20-year-old student who is rather unremarkable. A history of some anxiety and depression through childhood, a little bit aggravated through later teenage years and early in studies. Living at home with parents and attending a local university where they're studying and doing quite well in their studies, generally speaking. Now, they've come to you because they've had 2 episodes, roughly 3 or 4 weeks apart, of sudden visual change. And on exploration of that, you would find out that they had experienced a horizontal hemianopia. So on one eye, the lateral aspect of their vision would suddenly fade to black. They were aware that it was black. They didn't have neglect to that side. Rather, they could acknowledge that there was blackness there that had, over the span of seconds, faded into blackness and persisted for several minutes before, again, over kind of 10 seconds or so, fading back to normal vision. They had confirmed it was just one eye by being able to close that eye and having full vision in the other eye, and there were no other associated findings at that same time. They were brushing their teeth the first time that it happened. Pardon me. And they were watching TV, a TV show with their parents the second time that it happened. There'd been no preceding trauma or head injuries sustained. There were no loss of consciousness events throughout. There were no seizure-like activity, and they'd never had seizures in the past. They'd also never had migraines in the past and had never had anything happen like this in the past. Both episodes seem to have lasted a similar duration in time, and there were no postictal or confused states following. They also noticed no change to sensation anywhere in their body. They had no change in taste or smell recently. And other than these 2 episodes, they have been perfectly fine in their day-to-day life. On further exploration, you would find out that no one in their family had had episodes like this. They don't know too much about their father's medical history, who passed away from a car accident when they were younger. But there is a family history of some kind of congenital heart defect with some kind of hole in the heart. And I think you're starting to perhaps see where this is going. Now, in terms of explaining your differential diagnosis to this patient, you should be exploring a rather wide variety of things here. And so going back to the history, there'd been no other flashes or floaters to their vision. There'd been no diplopia or blurred vision at all. It was just the strict hemianopia to one eye. So the first thing you'd be wanting to exclude, and one way to kind of make sure you're covering all bases here, is to kind of start from the outside and work your way back. So some of the things could be certainly eye pathology directly. So if you're thinking retinal artery occlusion, if you're thinking that thing that happens sometimes to the back of the retinal detachment. There we go. We all have brain fart moments. Retinal detachment, so lifting of the retina there. I think those would be valid things to state. But again, as we start to move further back into the brain, I think we're getting more to the crux of what's going on here. With this, you would think along things like TIAs or potentially even stroke if you want to go that far. Given the short nature and full resolution of these symptoms, they would fall more classically into TIA territory. On similar kind of vein, you could make arguments as a unilateral kind of orbital kind of pathology for things like a migraine or an atypical migraine, and that would certainly be worth mentioning. And tying the TIAs back to the family history there, you would certainly be looking at excluding a congenital heart defect, in particular a patent foramen ovale or some kind of septal defect that could be allowing for passage from one side to the other. So in terms of then what investigations you would like to order and why those investigations are important, essentially you're running a TIA workup here, so you'd be setting off for FBE, UECs and coag studies as well. Why each of those are important. FBE is going to show you platelet count. If there's some kind of coagulopathy there, you may see relevance, or anemia as well in terms of oxygen carrying capacity and perfusion capacity. Could also return positive white cell counts if there is some kind of unusual infection taking place, but certainly less likely in this setting. UECs will be for renal function, and certainly we do know electrolyte disturbance and abnormalities can have a profound impact, so you're wanting to monitor your sodium levels there. You could make an argument as well for things like calcium levels as well. And likewise with that, we do see funny neurological deficits with iron deficiency, and you could make an argument there for FE studies as well. Coagulation studies would be to assess for hypercoagulopathic state, which again would increase your risk of thrombus formation, TIA and stroke presentations. With this, you'd also want an ECG to check for arrhythmia. In particular, you'd be looking for things like AF or irregularity, which is prone to promote clots. And of course, the big ticket item I really want to be seeing here would be a echocardiogram to assess for patent foramen or septal defect. Now, you could also make an argument, of course, for neuroimaging, and I think it would be quite reasonable in this circumstance to be looking at some form of imaging, CT brain or MRI brain, depending on your particular feeling of how aggressive you want it to be, and if certain aspects of the history had kind of swayed you more one way or another. Certainly MRI brain is going to be more sensitive if you're going down that stroke-type pathway. In the absence of any specific trauma or other red flags, CT to exclude acute hemorrhage or hemorrhagic events would probably be slightly lower yield in that setting. Tying into that, things like MS, you will potentially be more likely to pick up from a MRI brain, although there's no other significant red flags for MS at this point. But again, we do know young age and atypical presentation. It's certainly a possibility there as well. Now, in terms of concerns the patient may have, the questions here are going to be things along the lines of, well, is this going to happen again? And this is where I think we excel as GPs in terms of being able to acknowledge the uncertainty of the situation and say, look, I don't know. Given it's unclear at the moment what the cause could be, I can't say for sure that it is or isn't going to happen, but what I can say is we are going to take measures to try and work out if we can identify the cause, and if and when we can, to then treat that or try to minimise the risk of any further sinister events from occurring. Now, advising the patient of your initial management plan, this is where you can also have the opportunity to organise these investigations as well as safety net this patient. So I would be ordering those investigations we've just discussed, and I would be trying to get those as a priority. And if that means calling radiology and seeing if we can get an urgent appointment, I think it would be certainly indicated in this case. Now, I'd also be talking to the patient about our fast signs for stroke and to advise them that if they have return of this type of episode, that they should be actually calling for an ambulance and attending emergency. Important to reinforce, they should not be driving themselves, given they are going to have vision impairment, and given it's unknown if this could evolve into anything further, we'd be discouraging them from undertaking any risky activities such as driving themselves. Now, we would also be organising a time to follow up that patient, so setting a appointment time. Pardon me. Setting an appointment time up to actually go through these results and make sure that this patient is not being lost. You could make an argument to actually send this patient to ED if you're in an area where these investigations would be taking quite a while to occur. Oh, and with investigations as well, sorry, I should double back. I'd be thinking along the lines of things like carotid Doppler as well to check for atherosclerotic plaques. Of course, in this circumstance, in this age bracket, it's probably going to be quite low yield. But again, if you're doing the full TIA workup, you could certainly make arguments for it. Now, that's essentially the management plan that they would be looking for. There's, of course, always going to be a few loose ends, and part of that's going to come to the particular things that you pull out from your history and examination findings. You could ask for examination findings, although in this circumstance the examination would be completely unremarkable for that patient. And again, the STEM here is really tried to reinforce, focus on the history from the patient, and certainly any information requested would be given freely. Now looking again, we still have a fair bit of time on the clock, and so here we could also then look at some of our more preventative measures. So things like actually checking, what is your height, what is your weight, how active are you? Is there potential to try and improve risk factors by managing those lifestyle factors? And certainly the big thing here for realistically any 20-year-old uni student's going to be looking at that alcohol consumption and saying, look, certainly if nothing else, while we're investigating this, while we're trying to get on top of this, we should try to minimise any alcohol consumption to just try and eliminate that from a potential contributor to this picture, and reinforcing the kind of healthy drinking standards for Australians being a recommendation of no more than 2 drinks per sitting. With abstinence being preferred in this particular setting until investigations are completed. And look, we've still got 4 minutes on the clock. You could also consider things like STI screening if they are sexually active, not really indicated for this case, but something you could explore as well. Certainly things like syphilis can present with atypical neurological findings, would be quite unusual for a 20-year-old, but hey, you never know if you don't ask. And certainly then you would also have the opportunity to try and explore further exactly what do you know about the family history of heart defects, how many people have them, what's been done for them, have people needed surgery. Again, that gives you a bit of an indication of severity and locations. And in this case, you would clarify that yes, multiple family members have had surgery and multiple family members have had strokes from them. All right, now we still have 3 minutes on the clock, guys. I think this goes to show that you really can cover a lot of material in that 15-minute time. So make sure that you take a few deep breaths, pace yourself, and again, have that structured approach to make sure that you're covering everything that you want to be covering and not missing things that would otherwise cause you grief. Let's, for the sake of today, get out from there, and very well done. Congratulations on those that have stuck through. Good to have you here with us again tonight. Hopefully this is helping your study. I'd really love to see in the comments below if you are finding this helpful, and I would really love to see some of you jump in and participate through Video Ninja and live chat to interact, and we run through some of these cases as well. I know it can be a bit intimidating throwing yourself out there, but again, if you don't practice, it really is going to be limiting your ability to progress and improve your knowledge and presentation skills. And what better way to practice than to use the same similar systems that they would be using for the exam. Now, thank you once again. It is 9:15, so with that I'll leave you all to a lovely night. Hopefully you all have a good little break before waking up for tomorrow, where of course we're going to go back for another day of generally practicing. What a terrible segue. Sorry, guys. Have a great night, and I'll see you all next Wednesday, 8:30. See you then.